This podcast cannot and does not contain medical or health advice. The medical or health information is provided for general informational and educational purposes only and is not a substitute for professional advice. Accordingly, before taking any actions based upon such information, we encourage you to consult with the appropriate professionals. We do not provide any kind of medical or health advice. The use or reliance of any information contained on the podcast is solely at your own risk.
Living in a world with an old soul. These rich men know the rich men, Lord knows they all just wanna have total control. Wanna know what you think, wanna know what you do, and they don't think you know, but I know that you do.
All right, and welcome back. So, continuing with Where There Is No Doctor, we are still on Chapter 10. We had just left on page 83, finishing up with nosebleeds, and now we are getting into cuts, scrapes, and small wounds.
3 episodes of No Where There Is No Doctor.
Yes.
This is psych. We're still going over it.
Oh, yeah. Absolutely. Yep. Still gonna be a thing. Still gonna bore you to tears with the opinion you have paid so high for on our review of this book.
All right. So page 84 on my edition. Cuts, scrapes, and small wounds.
Mm-hmm.
I mean, I don't think there's anything too controversial here.
No.
Making sure that you get up in under any flaps of skin, make sure that's all cleaned out. Irrigating the wound. I mean, I just wrote in on my version the phrase "the solution to pollution is dilution," just like sterile water or boiled water, cooled, something clean, and then there's more volume than you probably think you need to just wash that wound out.
I wrote in Dakin solution.
Yes, that is something that introduced me to that concept.
Yeah, this is a great place for this. Man, I really should have. Damn, I didn't do my due diligence on this, and I apologize. You're gonna have to hear me type and Google things.
I believe there's a formula for it in improvised medicine, and I believe there's a formula for it in the Alton book.
There's also a recipe in the CPGs, the wound care.
Okay, hold on a second. Stand by. So if it's in the CPGs, it's probably in the 2014 version of Emergency War Surgery.
Potentially.
Let's see here. La-di-da. Wounds and it's a spinal cord.
That's quarter strength. Oh, good.
Soft tissue and open joint injuries. That sounds like fun. Let's see, do they have a glossary? Ah, they do. Aha.
Here we go. So with boiled water, 5.25% Clorox, well, not specifically Clorox, but 5.25% bleach and household baking soda. You will use 32 ounces of tap water, boil it. This is for 15 minutes with the lid on the pan, remove from heat, add half a teaspoon of baking soda, and then measure the bleach. This is to use 3 ounces. That's for full strength. Use 3 tablespoons full and plus half a teaspoonful of bleach for half strength. And what we want to do is use, at least per the CPGs, recommends using half strength, and then you dilute that 1 to 10. So 1 part of the half strength, 10 parts water to get what you're going to rinse with. And that gives you 10 liters of solution that you can rinse quite a bit of stuff with that. And basically, regardless of whatever you're using to to rinse. And I don't know what it. Okay, so it does say this down, at least on my edition. At the bottom, it says never put alcohol, tincture of iodine, or merthiolate.
Yeah, I looked that
Close
up.
enough.
I looked that up, yeah. Because there's different names for it, but I think what they're referring to is benzalconium chloride from Bayer of Mexico, or they would say clorero de benzalconia tintura. I just wrote that down, so I had to say it. And I also wrote in hydrogen peroxide.
That as well. Yeah.
Specifically, they do list the alcohol.
Yeah, don't put them directly in a wound because it will damage the flesh. It's also going to kill all of the beneficial, your staphylococcus that you have that just naturally exists on your skin to prevent other bacteria from taking over. You're going to kill all of that as well and make things a lot slower. So yes, when you were a child and you thought there was no purpose to the burning from the hydrogen peroxide on the bathroom counter, you were correct.
Well, okay, I'm gonna argue that a little bit. Of course. If you have a contaminated wound that has like dirt and junk down deep into a wound, the bubbling action of hydrogen peroxide can help try to kind of bubble some of that up out of there. But after that initial wound cleaning, there shouldn't be any need whatsoever for anything that caustic.
I will counter argue that counterpoint with gentle low pressure irrigation will do the same thing.
Would be best.
And the CPG state, so it's not stated in here, but in the CPGs, in the wound care CPG, it states that from what they, and I don't know if they cite the specific study, but it says that like there's been found that there's no benefit from using any sort of additive versus just Dakin solution or even just clean water.
So what you're saying,
massive irrigation for using, and like, cause we're not just like using like a cap full, like we're talking about like using like a liter, 2, 3, 4 liters of fluid to gentle with like a bulb syringe, gentle irrigate a wound to get all of the contaminants out.
So what you're saying is I shouldn't use on non-living tissue what I would use. I shouldn't use on living tissue what I would not use on non-organic material.
True.
So that the same thing that I would use to clean stainless steel isn't what I should use to clean my soft pink body.
Probably. Yeah.
Yeah. That's that would be hypochlorite. Okay. I'm trying to see if they have. I thought they had a formula for Dawkins or Dakin's solution in here.
In
the improvised medicine book. And of course, now that I'm looking for it, I'm not finding it, of course.
It's a little bit hard with paperbacks to control F.
Yes. All right. Well, anyway, I'll stop perseverating on that.
But yeah, okay. other than that, and that was the only addition that I had was just simply adding in Dakin solution. Everything else here is pretty, like using clean tweezers or a piece of clean piece of cloth or gauze to remove bits of dirt. This is to always boil them first to be sure they are sterile. Generally with any like exposed underlying tissue, you want to make sure that you're not introducing any new forms of bacteria or any other contaminants or, fancy word, bioburden into the environment, into that wound. So main thing is just keep it clean. Get it clean and keep it clean.
Yeah, so speaking of that, as far as keeping things clean, one of the things that they talk about on the they bring up this one example on the PFC podcast quite a few times of the people that I don't know what this particular scenario was, but the people that got their wounds got more attention and got their wounds changed more frequently did worse than the people that didn't. And I think that would be in the context of a very dirty environment. And when you can't guarantee a clean change.
I don't think it matters. It's just the number of touches.
Yeah, so like that's what they observe. Like it's very much counter to what we think of. We think, oh, change that change that bandage every day. And that's not what they found in
Yeah.
in people. So
Yeah, I've read similar and heard similar, that kind of letting dressing changes go a little bit longer. Because the argument always is like, well, I need to see if there's an infection. There's other ways. But that's a whole separate can of worms to get into as somebody's particular opinion on frequency of dressing changes.
it's just a counterpoint to the change of dressing every day
Yeah.
dogma.
Yeah, we need to. But
So, all right, large cuts, how to close them.
Well, the other thing I had on here that I just
Okay.
reread. So it talks about using like an antibiotic cream like Neosporin, and it just says to apply a thin layer. I want to specify that that is not like onto the damaged skin. That's like up to the edge of the undamaged. You don't want to put that like directly onto the wound because it's not meant to work there. Like even if you read the directions on the tube of Neosporin, just for topical use only.
I know. Well, I always took that to mean don't ingest it. That's what I always thought. Like whenever it says topical use, it's like don't ingest it and don't put it in any orifices. Let's put it that way.
Would the wound not be considered an orifice?
Not one of the ones God gave you.
I mean, this is true, but semantics,
Yeah.
they're fickle. Large cuts. So the only thing I think I might have prematurely wrote it down.
Bacitracin being another big one that Dr. Lee likes to talk about. He's a big fan.
It's really good for burns. That was actually so like they always say like don't put creams on burns. I remember being told specifically like you can put bacitracin like on burns. That was something that we were taught for pre-hospital care.
Yeah, I'm not dogmatic on the neos on this, but I was always under the impression that the medicated barrier gels like Neosporin or bacitracin was to prevent bacteria to get into that wound, and so that it was okay to put it on the wound, but I would have to look that up for sure.
Yeah.
But yeah, I just saying topical use only. I think that really just translates to don't eat it, no matter how tasty it smells.
Yeah.
No matter how good it looks in the commercial.
I can't remember where it was that I had that like explained to me by I think it might have been on Prolonged Field Care.
I mean it could. I'm not saying I'm not dogmatic on it. Just like
yeah.
I've never heard don't put that in a wound or as far as Neosporin in like in a cut versus along the edges of it. I mean, along the edges of it is good.
Who cares? Because if you can put it along the edges of an open wound, you can put it in an open wound.
I don't think there's anything contraindicated of putting it in the wound, but I don't know. That's an interesting.
I'll have to find where I heard that.
Yeah, that would be interesting to hear where that's coming from.
But just as far as safety goes, like if you can put it on a wound margin, you can put it in a wound.
Yeah. He was referencing the topical use only, and my contention is that
don't eat it.
Don't. No matter how good the model makes it look in the commercial.
Yeah.
Don't eat it.
For someone who might think of this like don't use it for like lubricating a suppository.
Oh yeah. Don't lubifoliate with it.
Yeah, exactly.
Oh man.
That's what it. I'm pretty sure that's what it means. It's like mucous membranes need not apply.
Oh, there's all kinds of stuff that you can think of, like ways not to do things.
Man. Okay.
Hey.
Gotta process that for a second.
Just picturing lubing a Foley with it.
It's
Oh.
yeah, it's fine when you're like imagining it happening to someone else. The problem is like when like your brain is just like, but what about if that was you? And then you just like, ugh.
No. The problem is when you try it on someone else and they reach up and strangle you.
Or you can move an MPA with it.
No.
Probably not a good idea.
No.
Yeah, that's not an actual
Probably
suggestion, guys.
probably not.
just to clarify.
Oh, thank God for disclaimers.
He said,
I want to just cut this whole bit out.
"Oh, I am not Dr. Lexus, and that is my summary." So do your stuff, man. It's all
God
that
for
stuff.
disclaimers. I don't. I'm looking now, and I don't see it here. Of course, I could just be like not reading it, so I'm not reading the right thing. But maybe it is somewhere different. But I wrote on here because it's talking about like close a deep cut only if the following are true. The cut is less than 12 hours old. Cut is very clean, and it is impossible to get a health worker to close it the same day. I wrote in here delayed primary closure question mark.
Yeah, so
I can't remember if that's referenced later on in this chapter.
Delayed primary closure being actually using something to close the wound versus secondary closure, which is just the wound closing from the bottom
on
up,
its
you know,
on its own.
Basically needs a bigger scar, you know, generally speaking.
Yeah.
It'll do
That
it.
was it was just something I remember hearing it on the prolonged field care in the literature and on there talking about, and they've kind of made reference to it several times about how like you don't need to worry about closing everything you find immediately. Like some things can kind of go for a while before you have to worry about closing them.
I know that. Well, so for example, they were talking about wound debridement.
Yeah.
And they were saying like that's something that it's not an emergent deal, right? It's like this is something that this can wait until the next day after you've dealt with life threats and you've stabilized for a multitude of reasons that we don't need to get into here. But that was where they were talking about that just from the standpoint of, hey, well, for one, just one thing, if you debride a wound, you know, cut away tissue that appears dead, when tissue doesn't have an actually adequate blood supply and there's going to be a lot of tissue that looks underperfused and sickly or dead. That's actually not. It's just blood pressure isn't where it needs to be. They're still low on blood volume, and you're possibly cutting out healthy tissue that you wouldn't otherwise.
Yeah.
On the cut, the whole cut is very clean is where I wrote in, or you can trim ragged edges to make it a clean, cut that you can put edge to edge. Like you can very much do that. Have done that, if it's a ragged cut or something, and just like if there's
that would be something I would want
extra skin
to get them to clarify, because when I read cut is very clean, my autism did not go to clean, neat edges. Mine went to it's not dirty.
Oh,
You can
okay.
make a dirty cut clean.
I mean, you can.
So I don't, and again, I don't.
Yeah, I guess I saw that.
That makes sense because later on it does say before closing the cut, wash it very well with cool boiled water and soap. It says if the wound is dirty.
Yeah, the use of the word clean there is not very specific. I assume that what it means.
I
is
hadn't
that
even thought about that.
Margins are nice and straight. The edges of the cut are straight, versus a ragged cut. Well, that's why we have these conversations, because like we read that and saw two different things, and
yes,
it really could mean either one. I don't know. So when they say very clean, if they say the cut is clean, I think, ironically enough, given English being an interesting amalgamation of languages, but if I say the cut is clean, I think in the terms of sanitation. If they say the cut is very clean, I think in the terms of mechanism of injury. It's weird, but that's just how I process that. Remember this, there was no doctor involved in writing this. To my knowledge, there was no clinician involved in writing this. So
Oh man.
So, Stella, come.
Um. So, and then they talk about butterfly bandages.
Come.
And they've got like a picture with some descriptions of butterfly bandages on a hand, doing it on the palm right before the thumb, and then on the
Mhm.
wrist. The
What is
only
with
so the only thing I would do on this is I would try to immobilize the hand so that way he doesn't aggravate, especially the cut on the hand itself.
Hmm.
I could
I
see if
was
that thumb's
curious.
not immobilized.
I'd like to understand what the underlying reason why they make those cuts to make a butterfly bandage. Is it just to minimize the amount of the wound that's covered and therefore potentially goes anaerobic?
No, because dairy strips don't have notches. I think it's to give you an arrow for wound goes here, dummy.
Hmm. Okay.
Maybe.
Maybe. I mean, that seems very specific, though. I don't know. That's just odd to me. Like,
Let me look up the history of the butterfly bandage and maybe I'll be able to tell you.
I
yeah.
mean, we did just talk about it. There was not really a clinician used in, so maybe like he read something about butterfly bandages and assumed they have to look somewhat kind of maybe
Cool.
if you squint hard enough and think of the right
Because all the
Rorschach, it
commercial
looks
ones
like a
will look good.
butterfly.
I don't know. This could be cutting the ends off the ham,
Um,
which is a family story about like in our family when cooking the Thanksgiving ham, like they always cut the ends off of it, and like why they didn't know why, it was just the way mom did it, right? Okay, we always cut the ends off the ham. And then finally we asked grandma, why did it? Oh well, the pan I had was too short for the ham, so I cut the ends off the ham. I was like, oh, okay, we've just been doing this for years without understanding
yeah,
underlying reason. So I don't know. I don't.
yeah.
Anyway, I just have a little question marks like what why are we doing this?
Hmm.
Or not? But anyway, so I think Koala Bear's looking up that and maybe get us an answer. But and then what everybody thinks about when it comes to medical stuff, and that is poking more holes in somebody
Sutures.
with purpose.
You got to boil horsehair and make because that's what they did in the Civil War, and if you don't know how to do that, you're gonna die. I had somebody comment that on a post a couple years back. He asked if I was going to teach about boiling horsehair to make sutures, and I was like, if it's that bad, we, I don't know if I don't know if medical is our biggest concern. I think we need to start focusing a little bit heavier on the spiritual aspect.
Well, if you don't like cats, you could always go for the cat gut solution.
Yeah.
It was never actually cat. What was it? Bovine gut or sheep or it was some kind of gut
I
though.
think it was sheep. Wikipedia stuff.
Sheep
Where I
or
found that stupid history stuff.
it was sheep or cow gut is what it actually was as far as the absorbable.
Yeah, it was something. It was something from a bovine, but I don't remember what it was.
Yeah, I want to say it was bovine intestine.
Some sort of ruminant animal.
Which, yeah, if I was gonna make something that's gonna get stuck through my skin, I think I would rather have it come out of a bovine than an omnivore.
Yeah.
Herbivore in general and the bovine. So it's like, yeah, this is like about as close to sterile as you can get. Specifically, like none of that's interested in none of the bacteria in there are interested in feeding on me. They feed on grass, or the remnants of grass. So, all right. That seems so. Other than like I say, my comments on that was like figure 1 and 2. Well, I got to specify on the bottom row where they show putting the first one right in the middle and kind of taking all the tension off the wound and putting the edges, approximating the edges in the middle. That's exactly how I was taught, because you want to take all that load all that tension to the center point, get everything. You don't want your subsequent stitches to have to be under tension when you place them, or minimal tension. And so you place that first one, and then you place your others, and then if that first one is now loose, because you've now kind of like tightened it up with your other stitches, you just take that first amount of pressure off with the first one, like, and then you put in your others, your first one in the middle might actually be a little bit loose because now that wound is tighter overall. So you might have to put it back in. You might have to take it out and put a new one in, and that's okay. But that's a technique so that you're not putting in a bunch of stitches and your wound is still not tight.
Yeah.
You're not close together. So
would you, since like we cut this in half, with the next ones, like, does it really matter the other? Because this one's showing like 5 totals, and I'm probably getting like way too deep.
I don't think I'd worry too much about that. Like it's the dealer's choice. I mean, I think if I had a super long cut,
yeah, you'd like split the halves in half again.
Yeah,
okay,
for sure. I mean, if I had a cut like that's like 6 inches long, I'm
yeah,
probably gonna have, 3, maybe 4 somewhere along there, just holding it together initially, and then I'm gonna put in my second row. But yeah, I'll probably put one in the middle, and then I'll put 2 bracers on each side of it, and then so the other thing with a stitch is you look at the width of your wound before you closed it, and you go about half of that width out into the skin when you take your bite. So you go, let's say you have a wound that in the middle where you're taking this first bite, that one in the middle is, I'll say it's opened up to about a centimeter. Now that's a really big wound, but let's say a centimeter because the math is easy, or let's put it in American, 1/4 inch. All right, so 1/4 inch. So I want to go 1/8 of an inch to each side. If it's a 1/4 inch across, I want to go an eighth of an inch to one side, 1/8 of an inch to the other side with my needle, at least, before I go through the skin. And then I want to come out at least a 1/4 inch away from the cut. That way I've got enough, just kind of a general rule. I've got enough skin, I've got enough bite to actually hold when I put tension on it, right?
yeah,
And then all my other stitches are going to be that same distance apart. And then the other thing is you're basically, your spacing of your stitches should be about the same amount of space in between the stitches as the stitches themselves are across. So going back to that, if I have a 1/4 inch wide in the middle, and I've got a stitch 1/8 and 1/8, so the stitch itself is, by the time I close it, is a 1/4 inch across. Then I want my stitches, my individual, like if I'm assuming like here they have simple interrupted stitches, interrupted being they're each tied off separately rather than continuous. But these interrupteds should be, in that example, about a 1/4 inch spaced away from each other. Does that make sense?
yeah.
So you're just trying to distribute load
Okay, yeah, that makes sense.
without knitting this thing a sweater.
Yeah,
And then they also put the knots all to one side. That's more of a little extra, like make you look like you know what you're doing.
If the knot doesn't sink into the cut and keep it from closing.
Okay. Yeah, that's okay. I've never had anybody explain that to me. It was just like, all right, put it over one side. It just looks neater.
Even in a dissolvable suture, if you are so blessed, the knot is the last thing to dissolve, and generally if you're using dissolvable on the outside of skin, the knot is going to fall off realistically. But if it's like stuck half into your wound, then you risk that wound opening up, or having a dehiscence is the formal term for it.
Yeah, dehiscence being that term for when it done opened up again.
Yeah, exactly.
Okay, yeah, that's a really good point. That's not something I'd been taught or thought about. Okay.
Almost no one's good enough to tie a suture with the knot only on one side, unless you're doing mattress stitches in which they're obligatorily on one side, just from how you run the thread. But you just take your forceps and grab the knot and yank them over.
Yeah, you just forcibly pull it over. Yeah, nobody's gonna make that happen. I mean, not nobody, but not me. And I think if you want to look up what a mattress stitch looks like, a mattress suture, I believe they cover that in Dr. Alden's
I think
book.
so, yeah.
I believe they do cover that. So, which, given that he's an OB, they do a lot of stitching and stuff like that. So,
yeah.
yeah. All right. So let's see. Anything, you are probably going to need use a needle holder, or what we call a needle driver,
Yes.
The hemostat.
You cannot control how many fingers.
You need something, clamp down on that thing and hold it.
Yep.
And we're not going to talk about the various profiles of needles. They illustrate it with a straight needle. Straight needle for this, what they're illustrating would be a pain. It would be doable, but it'd be a pain.
Yeah.
You want it curved.
Better hope you don't have some nook or cranny you have to be stitching in.
Yeah. So, I mean, you can make it happen. This is all steroid kind of thing, but anyway. Okay. Anything? Let's see. Only close wounds that are very clean and less than 12 hours old. Old, dirty. Yeah. Okay. All right.
One thing that it says in there, which has changed since this edition was done, actually changed very recently. You can close animal or human bites. And the book specifically says, do not ever do this. The research has shifted since then, and that like as long as they're less than 8 hours old and they're copiously irrigated, then they can be cleaned. If you want it, the caveat with that is like if you want to be a little bit cautious, then you only close like a face or a hand, like something that's cosmetically important. But if it's cosmetically important and it's fresh, you close it.
Yeah. All right. Any other thoughts on page 86?
No, not that I can think of.
Bandages, as far as like they illustrate various. I do kind of like the improvised finger splinting.
Yeah.
That's pretty good because, yeah, it'd be great if you have your own like pre-made finger splint aluminum deals, the prefab ones, but
Yeah.
knowing how to do that without just sort of general materials, it's really good. So several good examples there. Okay, and then as far as cleaning it, let's see, wrap it in thick paper, seal it with tape, bake it for 20 minutes in an oven. Now, putting a pan of water in the oven under the cloth will keep it from charring. So I know we've talked about dry heat, or PFC has talked about like dry heat with an iron. Using that. I can see if you're going to put something in an oven, you're not trying to make char cloth. I can kind of see that. So it's actually like a wet heat, or at least it's. I thought that was interesting. I don't really have an opinion on it. Just like, oh, okay, not actually a dry heat. They're trying to. If you're not trying to make char cloth, then a little bit of steam and just a little bit of moisture in there.
Yeah.
And when applying bandages, not so tight it cuts off the flow of blood. I would hope that would be obvious, but that's something that you cover really well in the T-Tri-C class, from what I remember of it.
Yeah, I wrote that in here. I wrote PMS before and after. You bandage something or splint something. So that's pulses, motor, and then sense. So you're just checking for a distal pulse or something that's further away from the heart than what you're bandaging or splinting. Checking motor function to make sure they can move that appendage, and then sense that they can still feel. And you'll do that before and after. And if there's any negative change, you did something wrong.
Yeah, and if you don't have a spot that you can, like, let's say you've bandaged the wrist and therefore you don't have access to the radial or ulnar pulses, you can always check capillary refill in the fingers.
Yes.
You're just squeezing the fingers until they go from pink to white, and then you're just counting how many seconds it takes them to go back to a normal color. It should take longer than 2, maybe 3 seconds. If it takes 5 seconds, or 2 to 3 seconds, longer than 2 to 3 seconds, you have a blood flow problem.
Or if they're white.
Or if they're those abnormal color changes.
When you're putting bandages on, just remember not to tape circumferentially around or a finger or a toe or anything. Don't make your tape go all the way around one of those things and meet again, because you have created a tourniquet.
Is that what you spiral tape?
Yep.
You must.
That makes sense
But
because
I'd rather not even do that.
he would, because he was. I remember in the T-Tri-C, both in the virtual and the in person when he showed it, like taping tourniquets in place. The spiral makes that makes a lot of sense as far as
Yeah, because
the
it allows for expansion.
Yeah.
yeah.
I remember like if you're dealing with any kind of line or whatever, I had a baby with an IV in a foot that the entire ankle had been taped around today.
Ooh.
It didn't end well. So child still has her foot and it will be just fine with it, but it's like that's not one you want to find a day later.
That's
Okay.
that's a method.
Is that
Yeah.
it just an inexperienced?
I don't know who this was. It was a transfer.
Oh,
I came in
okay.
with it.
Well, that's actually a really good teaching point, just as far as like
Check
when
your-
you get a transfer.
Check the interventions.
Mm-hmm.
Yeah.
Don't assume it was done right.
Yep.
Unless
Yeah.
you do
Yeah.
it,
Anytime there's a handoff.
Particularly lines,
Yeah.
tubes, and drains, LTD,
You-
lines, tubes, and drains. But yeah, that's something that again I had been exposed to the T-Tri-C material before, but taking both your virtual class and then your in-person class was really where I picked up little those extra things like the spiral
Yeah.
taping and things. Which the next T-Tri-C is actually coming up, isn't it? November 4th and 5th down in the G Camp.
Yep. Yeah. It's the 4th and the 5th.
Yep, that's coming up 4th and 5th, and then Partisan Lifesaver, December 1st to the 3rd. Again, they're in the G Camp in North Carolina.
Yep.
Which is basically more but better.
Yeah.
An extra day of stuff.
Yes.
Which I'm looking forward to that. All right.
Yeah, it's gonna be good.
Guys, I've never taken that with you.
Yeah.
All righty. All right, infected wounds, how to recognize and treat them. Okay, so I wrote some question marks in here, right? A wound is infected if it becomes red, swollen, hot, and painful. It has pus. And I put a little check mark. So those two I have question marks beside because like there are other conditions that can cause those things to happen. It begins to smell bad. Little check mark. It's like, yeah.
Yeah.
Aerobic bacteria, that's a unique smell, right? Like, so yeah, I'd say that's fair. There are a lot of things like allergic reactions that can cause something to be red, swollen, hot, and painful.
Mm-hmm.
And there are aseptic, basically pus. You can have drainage that's not infectious. It could be cancer, it could be other things, but it's not necessarily an infection. But like CC, it is infected if, and like, if you had all of those, highly likely, right?
Yeah.
But just the smell itself. I mean, I would certainly have it on my differential, but I just like you got to keep a broader differential than that.
As a medic I worked with used to say the smells, and he would do the little Italian handshake. You'd say it smells like a fine cheese.
Yeah. So the infection is spreading to other parts of the body that causes fever? Question mark. Again, what else is causing fever?
Yeah.
This is more a differential diagnosis thing to me, but red line above the wound, yeah, lymphatic streaking, sure, swollen lymph nodes, tender lymph nodes. They give some illustrations. Okay, so the hot compresses on the wound kind of help try to get any kind of infection drawing to the surface so that we can get all that drainage to the surface so that hopefully it'll either self-drain or we can help it along a little bit. Hold an infected hand or foot in a bucket of hot water. I guess if you can't do a compress, that's the idea. My question is how hot? Because I have concerns. I'm not sure on that.
Obviously, just to clarify, obviously we don't mean to suggest that you should take a freshly boiled pot of water and proceed to attempt to make a European mount out of somebody's hand or foot.
Oh, I'm. Oh, yeah. So let's put it this way. Okay, it's kind of like when we. It's kind of like when we're bagging somebody, or doing rescue breath, or particularly bagging. If you need to breathe, so let's say we're bagging someone as far as we are breathing for them, right?
Using a bag valve mask.
We're using a bag valve mask to breathe for them, right?
Somebody very rationally pointed out at one point that's like, for somebody who doesn't realize what that particular term means, it sounds like you're putting them in a body bag.
Oh. Well, hopefully the next thing I was going to say would clarify that that's not what we're talking about.
Well, if it goes poorly.
But even so what I was going to say was, if you are bagging someone, if you need to breathe, they need to breathe. Was where I was going with that. So hopefully that would eliminate for most people.
Yeah.
That's a body bag, but you never know, you know.
Reminder, just be careful how for everyone, be careful how you phrase things around people who don't know what's happening.
Phrasing.
Yes.
So okay, so again, yeah. So if you're giving someone, if you're in control of their breathing, you're breathing for them. If you need to breathe, then they need to breathe. As far as like how much your rate of artificial respiration is, right?
Yes.
So if you can't keep your hand in that bucket of hot water, they can't keep their hand in the bucket of hot water. It's like, is that fair? It's like, I think that's fair. Like, how hot? Well, can you keep your hand in there?
Yeah.
Fine.
Boiling a frog, gentlemen.
It's like, all right, then that's yeah, I think that can be that's how I would use that.
Probably water you would be comfortable showering in.
Yeah.
And we say that to temperature in regards to the temperature that men shower in. Women, we know you like to return to the fiery depths of hell with your showers. We're not talking about that.
Yeah, I usually, if I'm right back from a run, I tend to want things a little cooler, and like, I'll have it warmer later. But I like things a little cooler when I just got back. But if you can tolerate it, then it's okay for them. All right.
Yeah.
I don't have anything. So if the wound has a bad smell or brown or gray liquid oozes out, or the skin turns black and forms air bubbles or blisters, oh Lord, this may be gangrene.
Well, I guess it depends on where the air bubbles are coming out of, because that could be something entirely different.
Oh.
If it's on the chest.
Yes.
Oh, yes, that is definitely more. That I would argue is not air bubbles in the skin. That is coming out of the deeper tissue. Yeah, you have a whole other set of problems.
Yes.
Wounds that are likely to become dangerously infected. There's a pig biting somebody.
Pig. Very obviously freshly pregnant pig.
Yes.
Makes me a little uncomfortable. It's just odd things, and I don't know if that has to go with stuff you could find in the Wikipedia article.
Hey, you went there after I skipped right past the lymphatic example that bears a striking to Michelangelo's David. And yeah. I let that one on by, but no, over this pig. Okay.
Look,
this is the Stuck Pig Academy of Medicine. So I had to get an honorable mention.
This is.
Though you gotta say it's kind of
yes.
It looks a little drugged, but
yes. I think an important distinction they made on here is wounds made where animals are kept, corrals, pig pens. So not necessarily something from an animal itself, but if you are, which again, with this being austere, the propensity of people that think the way that we think, and their rate of ownership of livestock animals, even in low quantities, you cut yourself in the chicken coop or in the goat pen, there's a chance that you can get. I mean, because there's. I'm just gonna say it like. There's not really like a good way to say this. There's gonna be poop everywhere.
It's poo.
Like if you've never been around chickens, they don't. Chickens and goats especially, they don't care. They're just gonna just poo everywhere. They're gonna step in it. They're gonna poop in the water.
Geese aren't any better, but honestly, I think pigs are probably the worst.
Yeah.
I think pigs are monogastric. They're like us. Pigs are the most like us, which is why they're the worst.
Yes. Yes.
Yeah.
If I have to hear another person say that because they don't sweat, all of the toxins go into their tissue, I'm gonna stab someone. Because that's not how that works. There's a reason why pig poo smells the way that it does, because that's where all the toxins go.
Oh, it's the same reason it's the same reason human poo doesn't smell very nice.
Yeah.
Yes.
We have the same stomach.
Our toxins are not getting distributed into our tissues. I hate hearing that. It makes me irrationally angry.
It's the toxic tissues. That's your problem.
That's what it is. I need
and you have too much toxin in your tissues.
I need to get those special foot patches, and I need to do a detox. I need to do a juice cleanse, guys. The tissues, the toxins in the tissues, they're getting to me. I need to do a juice cleanse.
Oh, all right. All right.
I'm gonna get an email from someone.
Hopefully get somebody riled up over this. Because we know it's like they'd much rather listen to us talk about like chest rigs, chest rigs and flash hiders. All right, clotrimazole. Just use Bactrim at this point. Trimethoprim, sulfamethoxazole. Because clotrimazole is not a thing anymore, I don't believe. Let's see.
Doxy.
Doxy.
It all comes back to doxycycline
and metronidazole.
Yes.
You're gonna ride your doxycycle and take the metronidazole.
Yes.
All right, so you leave the wound open. That's what we were talking about earlier as far as closing by secondary intention. You basically don't want to get bacteria trapped in there if you can avoid it. Because bites tend to be deep. So despite all that irrigation we talked about earlier, the likelihood of you missing something is higher.
Yeah.
I honestly don't know if tetanus antitoxin still has the allergic concerns that they talk about being made more. I don't know. I mean, I think in general, any kind of injection, any kind of vaccination or injection, you watch somebody for at least 15 minutes and just in general, that's a general rule.
Yeah.
What I've observed and how I was taught.
It's pretty safe practice.
So
there's always one or two at a battalion-wide PHA. There's always one or two that pass out. They generally all work in S3, and they generally always have rockers on their rank insignia.
I don't know.
But that's a different discussion for a different day.
I'm a great civilian. I don't know what S3 is.
Those that know, and they get it, and they probably chuckled.
Okay.
But I'm probably going to get, maybe, I don't know. S3 nerds don't tend to listen to stuff like this. I'm definitely getting an email now.
We haven't picked up nearly enough people this episode. We got to work on that. I gotta work on my. We got whole branches that we haven't ticked off.
I know.
All right. So yeah, chance of rabies. Yes. Do not mess around with rabies.
Yeah. No.
Bullet, knife, other serious wounds. Okay, let's see.
Yeah.
The cloxacillin is old, just amoxicillin's way to go. Clindamycin's still good to go. Um,
On totally random, apropos of absolutely nothing, but I'm doing laundry. Apparently, surgical bouffants are washable.
yeah, your surgical bouffant went right through the wash, huh?
Yep, it's still in my pocket.
That's nice. Hair cover that just went right through there. Going in the trash now.
Interesting.
They're a great look though, you know.
Well, especially when I already wear hair covering.
Yeah, well, I just remember like the blue bouffant, the blue gowns, you like this little blue powder puff, like it's all oversized on you. You're just running around the hospital. Yeah, little blue poof. Yeah,
You just see that and you have to wonder if Make a Wish decided to stop by unannounced.
it would be the wish. It would be the wish version of Frozen, maybe. I don't know. Yeah. The Blue Fairy from Pinocchio.
That's at least a kinder response than Teddy gave me, which was just like, yeah, the reaction is going to be that you escaped from the pizza psych floor.
Forget about a lot of things I say. I still apparently it touched a nerve.
She remembered it.
Yes, she did. Like I apparently I say a lot of things that I don't remember.
That I'm about to get another email. It reminds me of a really, really bad joke.
Said it.
You know how they say you never call a woman fat, and that's because elephants never forget.
Oh,
oh,
oh, oh! I think we lost one female listener, maybe. Because like most of the women on all the women on the internet are dudes.
And nothing of value was lost.
All right.
Yeah.
Bullet wounds in the arms or legs. Well, first of all, you thank the good Lord you didn't get shot in the torso.
Yes.
All right. If bleeding is not serious, let the wound bleed for a short while. This will help clean it out.
Oh dear God.
Let's get your thoughts on that. All right, so Mech Medic, tell me, like, should we let the bleed for a while?
Is this book written in 1982 or 1882?
Oh, that's funny. I wrote just
oh
a question.
My God.
You don't want to let it bleed out, but think about like when you're debriding dead tissue, you want to see a well vascularized wound bed.
Yeah.
It's like
no,
but
I mean that's.
It's gonna bleed as you clean it anyway. It's gonna bleed as like don't intentionally tell people to let it bleed. Like don't intentionally tell them that. It's great. We just let the wound bleed, and they were really in pain for like the first couple minutes, and then like they just went to sleep. And they were like no pain. It was great.
Why is it always the people that say shit like this that also say stupid shit like if you put a tourniquet on, you're gonna lose the limb? Like they're always on somehow like both ends of the spectrum. And like as somebody on a spectrum, I can like
Krisky. Oh god.
But like oh man, no, don't intentionally like bleed people. No, stop.
We're gonna get with this. This is good. This is getting better. All right. All right. So in the case of a gunshot wound, wash the surface outside only. It is usually better not to poke anything into the hole.
Yeah, so this isn't a spaghetti western. We're not gonna go like digging into the wound to go pull the bullet out to make it better. That's not how that works.
Yeah, but wound packing is a thing.
I mean, yeah. This is I'm assuming because they've already said they've controlled the bleeding at this point. This is like after that, but and they do give antibiotics pretty quickly after that. That is important.
Control the bleeding is shown on page 82. Oh, okay, but I'm just like,
What's the control bleeding?
Don't mess with, don't like just mess with it for the sake of messing with it.
Because I know we already talked about it, but oh god, it's raise the leg. Yep. Okay, there we go. That's I forgot that was the other terrible advice they gave.
And also give under their give antibiotics, I wrote appropriate.
Ertapenem?
Yep. That never gets old. At least not for me. Oh,
real life administration, and
I start cackling.
A pack of hyenas in
I start cackling. I raised the thing about like they say just give antibiotics, and I wrote inappropriate, and then what I hear from the other end of the line is Ertapenem.
For the last time, no. More. One needs to cover for Pasturella when you're talking a bite. That's what it means by appropriate.
Yeah. Gram positives, penicillin. Yeah, that's.
I need to meet.
We're on to bullet wounds now. But yeah, it's still like gram positives is going to be a big deal because you punctured the skin on the way in.
Yeah, but yeah.
Okay. So
I need to meet an infectious disease doctor so I can like have that conversation. Like, oh, what are the antibiotics you use? And I want to get like a recording because I want to be able to watch his face like over or her face over and over and over as I just like I'll just get this grin and I'll just
Ertapenem. Doctor somewhere keels over and decides to leave the field.
Yeah, every time you say that, an ID doctor dies. Well, yeah, it retires. It retires in frustration. Every time you say that, House sends somebody else to the MRI.
Oh man.
I was watching of all his malpractice, and I'm like, I thought Mech Medic was exaggerating, but good Lord, he wasn't. When you see it all in close proximity, it's like when you're not Stockholmed into like liking this guy, you're like, this is horrific. Oh my goodness.
Yeah.
All right, so yeah, elevating the legs, bogus. Okay. And then
so we have talking about a break, not putting, and I'm frustrated that the break that they choose to show is a femur, and they say absolutely nothing about providing traction and traction splints, because that is, if you have a break that drastic of the femur, like that's not just like a
traction's an important part of a lot of like any kind of displaced fracture, right?
Well, I just mean specifically like with the femur, like it's pretty much a guarantee that you're going to have to do some pretty severe traction on a break, like what they're showing on a femur.
Right. So, I mean, I've slipped and slid on the ice before, but let's talk about let's talk a little bit about what traction is. Okay? It's nothing to do with that one time that I hit that slope with my Forerunner and spun around, and I'm like, oh, okay, we're doing this now. Four-wheel drive. So traction is just where you're basically pulling on that limb. You're trying to counteract the natural tension of the muscles in that part of the injured limb, because that bone is working like a strut. It's the muscles have to have something solid to pull against. Like when you if you stand up, like from a sitting position, I happen to be sitting now. So if I stand up, my muscles contract to make the hinges of my knees and my hips straighten out, so I'll stand. But they have to have some sort of hard strut to pull against. If that strut is in two pieces, those muscles just naturally, and they're in pain, so they're going to contract. Those two pieces now get pushed past each other, and the overall thing gets shortened. So in order to get that to set properly, you have to physically pull those muscles. You have to counteract the tension on those muscles in order to allow the bones to line up.
Yep. Yeah. The other concern is that you have broken, ragged bone running alongside long bone, and there's other things that run along long bones.
Yeah, neurovascular bundles run along the inside of bone because generally speaking, they're most protected there. But if their protection has now been compromised, now instead of them sitting beside the safest location. They're now beside these jagged edges from this broken bone. So yeah.
Yeah.
All right. So they
You have
talk about
more.
as far as in their next, like right below the not elevating the leg, or not, or don't elevate now.
Yeah, they want you to keep it elevated.
Um,
Because that somehow is going to heal faster and is less likely to become infected. Because that's what you want to stop an infection, is less blood flow going to.
I don't understand the walking on an injured leg or sitting with the leg hanging down will slow healing and encourage infection. I don't know where that's coming from. I guess they kind of draw it like there's edema, so I kind of understand that, but
I think that might be related to how tight they have that
yeah, I'm
bandage
wondering
wrapped.
that. Yeah, I'm kind of wondering that, but
Uh,
the thing here is like you need to get early PT and get somebody back and work
mhm.
on recovery sooner. I think that's
Yes.
seems to me to be the missing ingredient, not like positioning so much. Is
Mm-hmm.
you get this person up and moving.
Yeah.
All right. You mentioned it before. Bubbles the chest wound.
Yes.
Take it away.
Something's fucky. And only certain people are going to get that reference.
I finally got that right. It took me a couple seconds. Yes.
Um,
I never watched that show, but my brother did. He greatly enjoyed it.
it's you have to.
I just enjoy the memes.
It's so good. I know a guy that describes himself when he was 14 as a self-described J-Rock.
All right, I'm lost. That's okay.
He's going to listen to this and he is going to appreciate that.
Not spam watches Trailer Park Boys.
That will come later.
That will come. All right, fair enough.
Just for the humor, just for the memes. So deep chest wounds. So apparently you're all out of chest seals, and saran wrap and plastic bags, and anything else that's occlusive. And we are spreading Vaseline or this mystery thing called vegetable fat.
Is that what happens to you in your 40s?
No, I think that was the guy that got Nobel Peace Prize for astrophysics.
Okay. Yeah, that's what happens when you become a couch potato. You become a vegetable fat. All right, moving on.
So you're spreading that on a gauze pad or clean bandage and wrap it tightly over the hole.
Like this.
And then they say, caution, if the tight bandage makes breathing more difficult, try loosening or removing it. Man, if only like somebody had invented this thing that came on like a roll and it was like cloth or some sort of material with like adhesive on one side, and you could like pull strips of it and you could use that to secure objects to other objects. So you don't have to circumferentially wrap somebody's chest to secure the piece of gauze to it. I mean, that's
tape in español.
That's a $1 million idea right there. So yeah, don't do this. Instead, if you don't have chest seals, just get a plastic bag. They're kind of everywhere.
The plastic bags for gloves,
right? Man, it just, oh God, it's just like, man,
it's a method.
I don't even know if it qualifies as that. Like, it's so bad. And then put the injured person in the position in which he feels most comfortable. Yes. If there are signs of shock, give proper treatment. Page 77.
What the heck is page 7? I've already forgotten what. Oh, elevate.
Probably just the normal like shock protocol.
Elevate the feet. Cover them with a blanket if they can't. do that.
Of course. Just ignore the tension pneumothorax and let's wrap them in a blanket. At least that way they'll be warm when their lung collapses and they die of cardiac tamponade.
Yeah, so people love to throw around the term tension pneumothorax, right? It's fun. So okay, so first, what's a pneumothorax?
Air in the chest cavity outside of the lung.
Right. So what is a tension pneumothorax? What is that tension physiology? What's happening there?
Pressure is causing the lung to either partially or fully collapse.
And do what to
and
the
it's starting to push on the heart and the other lung. And that pushing on the heart is going to constrict it, and that's what causes cardiac tamponade, which is where the heart isn't able to expand as fully, so it's getting less blood to push out. So you start seeing issues with blood pressure and other things.
Yep. So that bubble of air inside the chest, but outside of a lung, is, like you said, it's getting big enough where it is pushing lung and heart and big blood vessels and airway to one side and compressing. And that pump is not doing well when it's partial.
No.
It's like taking the heart and just gripping it from one side. Doesn't do well with that. So that's why everybody gets so worried about whether they need to decompress a pneumothorax. And it's like, is it a tension pneumothorax? And do you know what to look for? Because not all that pneumothorax sees tensions. You listen to some of these ER docs that see tension, that they see pneumothorax all the time. Like they'll identify it on chest X-ray, and a lot of the time they leave it alone unless it develops into tension physiology. Stick something in the chest. And this is something that I think people need to understand. Just because you have even if you have a pneumothorax doesn't mean you have a tension pneumothorax. It's like the difference between a bleed and massive hemorrhage, right? And like you're down the road on massive hemorrhage. Like, okay, you're like, all right, this is degrees of the same thing, right? So like you don't put a tourniquet on a non-arterial cut, right? If it's not massive bleeding or an arterial cut, why would you put a tourniquet on that if it's a superficial cut? Putting a chest dart in just because they have a hole in the chest.
But these guys on Instagram with a bunch of multi-cam black told me I need 14 gauge needle and I'm supposed to stab it in their chest. So that's what I'm going to do.
They're obviously right. Yes.
So on that note, so we have give antibiotics and painkillers. Bold choice, Cotton.
Well, with the caveat that when you give painkillers, you realize that you got to be watchful for if you have access to the really useful painkillers. You got to be careful of decreasing their respiratory drive. Masking altered mental status.
Generally, our rule of thumb is if they had some sort of issue, like if it was a chest wound, we weren't pushing opioids.
Yeah, I mean, especially because of the respiratory.
We didn't with the suppression of the respiratory drive. It wasn't something we wanted to mess with. Ketamine does not suppress the respiratory drive.
Right. Well, that
is a go. But that's not technically a painkiller. It's not technically analgesic. Yeah, it's a dissociative.
So you make them not care.
So yeah, you're still going to be in pain. You're just going to be tripping so hard you don't care.
It's not contraindicated to give opioids with chest wounds. It's like, don't snow them for
Right.
obvious reasons.
Yeah, I
but-
wouldn't even
Yeah.
say opioids. It's just like, particularly if you're a provider and you have experience
Yeah.
in training, either one, and
But-
hopefully both.
But it's like, if you have a chest wound, that is massively painful.
Yeah.
Sometimes you need some of the pain off so that they can breathe.
Right, that's a good
Yeah.
point. They may not have normal breathing just because like it hurts to breathe.
Yeah, like their body is fighting them trying to take a breath because they're splinting. Like
Yeah.
their muscles are trying to hold that injured area steady and still.
I mean, anybody who's had a
Yeah.
stitch understands that.
Yeah. I think that was specific for us being pre-hospital, just to and then like being slightly austere, limited number of people that can actually like monitor and handle the casualty. I'll have to go back through and check because
What
having to
painkillers
dig
do you
deep
guys
to remember
have
that.
access to?
What's that?
What do you guys have access to for pain?
Uh,
Loxicam was part of the combat pill pack.
Part of the combat pill pack, but that's just an
It's an
NSAID.
It's a prescription strength
Yeah.
non-steroidal anti-inflammatory drug, such as same class as ibuprofen.
Yeah. Morphine, fentanyl,
Okay.
lollipop,
Yeah,
the OTFC,
TFC.
OTFC, the oral
Oh, the trans like a lot the lozenge, the transbucal.
yeah.
Okay.
Okay.
Okay. So yeah,
and
so
then ketamine, and then
you have some good options there.
Yeah.
Fentanyl is a nice drug.
Yeah.
Yes.
It doesn't have the anaphylactic risk of morphine.
Yeah.
It's a lot cleaner.
It's a cleaner drug.
Yes.
My brain is tired. I don't remember the on-off times for it at all right now. But you can hit that window of getting someone out of pain enough that they can breathe and not.
Yep.
Yeah. But yeah, that's one of those where that's quite frankly, it's like if me as a provider, if I'm managing someone with a chest injury and quite frankly, in my context, we're talking an ED or an ICU setting, but it's like, yeah, they'd be on a fentanyl drug, 100%.
Yeah.
And that's even assuming no respiratory support.
So
Yeah.
both wounds in the head.
Make a shroud.
Make a
You're
shroud.
Yeah.
Okay, so I will say that this is like, I know we've kind of ragged on them about the raising the feet thing. But the half sitting position for head trauma is I absolutely agree on that.
Yeah. Yeah.
Doing something different, you're lowering the intracranial pressure.
Yeah.
Yep. That's your big concern.
So it's like, even though we've ragged on the whole raising the feet thing,
Mhm.
but raising the head in this context.
Yes. Yeah. That actually has a purpose. If you even know what isotonic normal saline is, let alone if you have it, this would be a pertinent use for the isotonic normal saline. And
That would be just
there's
trying to pull fluid out of trying to keep fluid or from building up in the intracranial cavity. Is that what you're going for?
Yeah. You're changing that.
I'm trying to think if it's isotonic fluid that goes for that. I think.
I'm sorry, I was out of the room. Can you say that one more time as far as what you'd be doing?
Normal
if
saline
I'm
or
isotonic.
Isotonic for normal saline for increased intracranial pressure.
Nope, isotonic is what you're going to use for hypernatremia.
Right. So I think you have to go.
You have to go
hyper something hypertonic.
You do small hypertonic boluses
because you want to pull fluid into the vascular space.
Yes.
And away from the CSF.
You need something that permeates the blood-brain barrier but still is going to drag the fluid back with it.
Yeah. And I am not
I am
not real good with this.
Yeah.
I'm not real facile with it. I know they talk about it on PFC for the
Yeah.
PFC podcast.
This is one of very few uses for 3% saline. Occasionally you'll find a 5%. I have never used that, and I hope I never do.
Yeah.
I mean, even dust off your college level stoichiometry for those who suffered that indignity, and you can make something less than 5%, even though that used to be the resuscitation standard 70 years ago. So, but yeah, you can literally draw out a brain with
Yeah.
3%. That's why you don't really do it as an infusion, you do it as a small dose bolus. I'd have to look up the exact dosing, it's pretty low.
Yeah. I don't know why I said isotonic. I most definitely meant like now that I'm like looking things up and like not just speaking out of my ass. I most definitely did mean hypertonic.
There are certain things like isotonic that just roll off the tongue, but
Yeah, it sounded right in my head.
Yeah, because I'm looking at my not my most recent copy,
Yeah,
but my most recent paper copy of Emergency War Surgery, the 2014 version.
yeah.
So I'm trying to see if they have something useful like that.
Yeah, hypertonic to 3%. Yeah, because that's changing the oh god, if I'm gonna make even more of an idiot out of myself right now.
Yeah, here they go. Here we go. Here you go. Okay,
Changing the solute gradient, if that's what the word is.
Yeah, you're basically putting in more salt in the vascular space, which is going to pull water off of the CSF.
Yeah.
So that's all.
So that's what I meant. I meant hypertonic. I just misspoke.
So if you really want to get into the nerd weeds on this, hyperosmolar therapy, but it's 3% normal saline is recommended for. This is from, just let me cite my source, Emergency War Surgery 2014 edition, which is, I believe, the 4th revision, page 228, top of the page. Let's see. It says early initiation of hyperosmolar therapy with 3% normal saline is recommended for a Glasgow Coma score of less than 12. May be given as a 250 ml bolus followed by an infusion. The goal is serum sodium of 154 to 160 milliequivalents per liter. Now, normal sodium is around
135 to 150.
Okay, I was glad I paused there because I was about to say the wrong thing.
You were about to give him seizures.
I was about to give him a systolic blood pressure as they're saying as their sodium level.
Which is the equivalent to giving him seizures from
Yeah, let's
sodium.
not do that. I was like, wait a minute. So again, normal, I always think it's 140, which is really a range 135 to 145. We're bumping that up where those are rookie numbers, so we're bumping up our serum sodium to 154 to 160. With the serum osmolality of less than 330 millimoles per liter, blah blah blah. See the clinical practice guidelines on severe head trauma. Okay. Again, for the listenership, I would really recommend that, as far as I know, the most recent version in print is the 2014 edition. There is a electronic version you can buy for like $1 or 50 cents. That comes as an EPUB from the U.S. government printing office, and you can get the 2018 version. So that's 4 years more recent than this, which actually matters with how much medical advances have come along. So the emergency war surgery, this is just off of Amazon. It's got the gravel quarry camo ACU pattern, but it is more recent than the 2004, I think. Why I had a 2004 version of emergency war surgery, and while it's not useless, there's been a lot of changes in that amount of time. Really ridiculous amount of changes in that amount of time. So anyway, that's why I like to keep those references handy for this kind of stuff, because I like my free version of things.
And then the only other thing I wanted to add on this bullet wounds to the head, I know there is some stuff specific. So ketamine had been brought up before, so I didn't want to talk about this. There is some literature that states that you should not use ketamine with TBIs.
Yeah, that
concussions. However, there was a study performed by a bunch of military doctors, pre-hospital use of ketamine in the combat setting, a sub-analysis of patients with head injuries evaluated in the prospective life-saving intervention study. and they compared, so going through life-saving interventions, analgesic data collected, documented head, neck, face injury, with an N value of 160. So going into no analgesic versus analgesic. Analgesic had 91. Ketamine was 46 and other was 45. So comparing other analgesic to ketamine, there was no difference in mortality. No difference in number of hospital days between groups, and the patients receiving ketamine were more likely to be discharged to continued medical care. So per this study, conclusion, use of ketamine for pre-hospital analgesia in patients with suspected TBI does not increase mortality rates.
When was this study done?
2020, January.
Okay. So that is probably not in the most recent version that I know of emergency war surgery, which would be 2018, or excuse me, 2018. So that's not going to include that. In the 2014 version, they do talk about using Keppra levetiracetam.
Yes, levetiracetam.
Yep.
If you have to run, sorry, I should have said that. If you're having to run hydroponics, you need to be loading with Capra.
Yep. That makes sense.
That's not something we had pre-hospital, so
yeah, load of 15
in a perfect world.
with a load of 15 milligrams IV with 1,000 milligrams twice a day. Okay.
Yeah.
And so basically you're lowering the side effect profile. Let's see, less side effect profile than phenytoin. Phenytoin's another one.
Kepra's much better tolerated, very safe overall, relatively compared to a lot of others.
And then they have their diagrams talking about drilling holes in people's heads.
Interesting.
Yeah.
So I posted a link to an article talking about that study in the chat. So if you wanted to look at that, let's take actually, you know what? No, we're close. Let's go ahead and let's call that for today, because that's a good chunk of it's over an hour.
Yeah. Can you post that link? I'm not seeing it in the chat. And then
is it not in the chat?
Not seeing it.
Huh. Okay.
I saw a little notification. Okay, there we go. Yeah. Well, goodness. Okay, go away. There we go. Okay, no, yeah, I was inadvertently closing it, trying to get the little notification to go away. Like it has had something in my face like I don't care, go away, and then I would close it that. All right, there we go. Open that up so that way I'll have that for my reference. Okay. So yeah, so we're now so that's it for now. We're at page 92. Next will be deep wounds in the abdomen, which is still very much something that you've got a lot more training on how to deal with than I do.
Yeah.
But something that folks over at Guerrilla Medic podcast like to talk about when they do their training small unit skills course. He talks about how he set up a scenario with a what's the term? Not an disemboweling, but an evisceration injury. He said,
yeah,
it is kind of get you, like ew. So
it's a little weird seeing it.
It is kind of like, oh, okay.
And they very quickly lose temperature. I remember that distinctly from the live tissue lab. It got cold very quickly, which is not a good thing. But yeah, so next time we will come back to that and get into abdomen. Anything else over the stuff we went through? We made better progress than last time, I will say.
Yeah, well, we'll get, yeah.
Well, actually, maybe about the same.
Okay, well, we feel better about ourselves. I'm feeling
we
better.
do. We do.
How you feel is all that matters. No, not so much.
Keep
Yeah,
it that
so
heavy.
my thought, unrelated to anything we've talked about, with just my little bit of thought for the day, thought for the week. If you can't find ammo, think about buying batteries.
Yes. Uh,
'Cause, yeah,
yes, and gauze.
gauze. Yeah,
Gauze. You never have enough gauze.
buy some good quality batteries.
Yeah.
If you've got nods, batteries for your nods. Got lasers, batteries for your laser. Got radios, batteries for your radios.
Yeah.
You got to always think we're going back into it. We're going back into a ammo drought with everything that's going on. So you need to
Mm.
think about all the other things that you could need, because you might or might not need to be pulling a trigger, but you probably going to want to be observing or talking or something, and it's going to
Yeah.
need power. So, and like I said, gauze. Yeah, there's lots of stuff like that. Heck, just OTC meds, just over the counter meds, like big bottles of it on Amazon or something.
Yep.
Um, simple things, and gloves. I still need to get good big box of baby wipes. All right, but that's my thought. Just we all get, yeah, everybody gets unhappy. I'm thinking mostly the Americans at this point, because I know we do have some folks outside the states. Right now we got a lot of folks who would be listening to this here in the states that are probably unhappy with the availability of ammo. But just
Yes.
you pivot to, all right, what else do I need to think about?
Yeah. Yeah, absolutely. All right. I don't have anything else. I will catch you guys later. Thank you for listening to this episode of the Stuck Pig Academy of Medicine. If you would like to join the Patreon, the link is in the show notes. Also, check out my training calendar for in-person classes. We'd love to have you.
It's a damn shame what the world's gotten to for people like me, people like you. Wish I could just wake up and it not be true, but it is. Oh, it is living in the